Good morning, guys. Hey, I hope you had a wonderful evening and I hope your morning is going well. I have Jamie here with us. She's from the CVICU and she's going to be talking to us about everything she loves and hates about CVICU. Hi, Jamie.
Hi.
How are you this morning?
I'm doing well. How are you?
We are good. I am good. Hopefully everybody else
I
is
have my
good.
kid here, so if she's making noise, I apologize.
Don't be sorry. You are a human too, and it's your day off, and you're giving us some of your time. So even if she sits with you on screen, it's a beautiful thing. It's totally fine. How old is your kid?
She's 9.
Oh, good. Well, so she's not going to be sitting on your lap, but
she doesn't start school until next week. So.
Oh, that's awesome. Good for her.
Yeah.
An extra 9 day or an extra 7 days at least out of school. That's great. My kid started this morning. It was a little bittersweet.
Aww.
Right? Okay. So how long have you been in the CVICU?
9 weeks.
So I'm super new.
Yeah, I'm actually still, I think this is my last week on orientation.
Okay.
And it's been rough.
Has it?
It just, I think no matter how much you try to prepare for it, it just is so much harder than you think it's going to be.
Okay.
The acuity is just insane. So it just.
What type of hospital are you at? Are you at like a level 1 trauma center, or what are you at?
So it's actually a specialty hospital. We do all cardiovascular. So, we see the sickest of the sick cardiac patients.
Sorry, I interrupted myself. So you said specialty hospital. Okay. So you see everything?
Mostly just cardiovascular, but we do get, we get sepsis and things like that, but our specialty is hearts and vascular issues.
Okay, but you see all types of vascular type stuff.
Oh yeah.
Not specialty to, I don't know, heart attacks or anything like that. Like
no, we see. Oh yeah. We do lots of cutting edge vascular surgeries, stuff that is not being done anywhere else. So that's pretty cool.
Medscape just published the new guidelines for vascular surgery and recovery, and I posted those in Elite this morning. Funny that you say that. So get them later on.
I'll have to check it out.
Yeah. So what did you do prior, since you're only 9 weeks into the CVICU, and how did it prepare you for what you walked into in the CVICU?
So I'm actually still a relatively new nurse in general. I will hit my 2-year mark in November. And I have been a cardiac nurse since I started. I've only worked cardiac. I never wanted to do anything but cardiac. And honestly, the thing that has prepared me the most is taking every class that's available to me. Basic hemodynamics, 12-lead EKG, patterns of infarct, doing lots of self-study on hemodynamics and drugs and how they affect, and what drugs you're going to use depending on what your goal is and stuff like that. I'm a pretty self-motivated learner, so which you need to be. But even with all of that, I feel like on a daily basis, I'm questioning, do I really know what I'm doing?
Sure. So what resources are you studying at home that you might recommend to other people interested in cardiac?
So I bought, I have lots of books that I buy. I just recently bought the CCRN exam study guide because that a huge focus in the CCRN is cardiac issues, and that talks a lot about pathophysiology and just how we're going to treat things, and so that has helped. I also bought a surgical perioperative manual, which goes over a lot of that kind of stuff. I took the Fundamentals of Critical Care Support class when I was still a new grad, which was an incredible course to take. And I'm actually going to take it again this week now that I've got some more experience under me.
That's a great idea.
I actually watch a lot of YouTube videos on hemodynamics.
That's good too.
Which helps a lot. So, and I ask a lot of questions. The docs I work with are always like, Jamie, come on. I'm like, no, but I want to know.
That's awesome. Good for you.
Yeah.
All right. So, is this a good place for a new grad to start? You have the experience firsthand as a new grad. Would you recommend other new grads starting as you have?
So I think if you are absolutely positive that is what you want to do, go for it. I will say specializing right out of school is hard. It's especially when you're dealing with such a high acuity of patients, because even on our step down floor, we will have 4 patients that are on titratable drips going for procedures, things like that at any other hospital might be in the ICU.
It's a 4-to-1 ratio?
Yeah. It's hectic. We have a high turnover of patients because we do so many procedures, and I can't tell you the number of days I've discharged 4 patients and got 4 back in the same day. So it's hectic. You have to have good time management skills. You have to be on top of your critical thinking skills. And it can be very overwhelming as a new grad to try and figure all that out while you're trying to learn how to be a nurse.
Yeah.
I would never discourage somebody. I would just say it's, I think, a lot harder than if you're starting with less acuity.
So did you work as an ENT or CNA? Did you do any entry level? No, nothing.
No, my previous experience, I worked in a hospital as an administrative assistant in education. So I did have that background, but most of my experience is like administrative in a law office. I have worked in an insurance company. I worked in childcare for a long time. So I was kind of a jack of all trades, a master of none. But I have known since I was 5 years old that I wanted to be a nurse. So
well, it sounds like you have a place for the master. That's exciting. Okay, so some of these questions are going to overlap a little bit based on the stuff that people have sent to me. So if you've already answered it, you may have a little tidbit here and there that you want to add to it. And if you don't, we can just say, oh, well, I already answered that. So how was your experience being a new grad in the CVICU? Any insight or advice?
So I technically wasn't a new grad because I had already been out about 1.5 years. And I feel like that was even a quick transition to the CVICU. But, I just think I would not encourage somebody to go straight from school to the CVICU. I think you need to get a good foundation of pathophys and kind of learn those time management skills,
Sure.
That kind of stuff before you go. I hear people say all the time, oh, the ICU is not that hard. You have 2 patients, or a 1-to-1. But I'll tell you what, with 4 patients, I could do my assessments, get them charted, and meds passed for all 4 patients by 10 o'clock. There are days that I look at what I need to do still with my ICU patients, and I'm like, how is this my life? It's different. Because the acuity is higher, you're having to do so much more. It just is, it's different. And I think having a better foundation before you go to the ICU is going to make you more successful.
Sure. It's interesting that your step down and your ICU have the same staffing ratios.
So we do it's usually 2-to-1 in ICU unless they are like on an Impella or a balloon pump or fresh out of surgery, then it's 1-to-1. But on a rare occasion, you might have 3 patients in the ICU, but those are usually like your post-op day 2 or 3 hearts that just need to walk and poop.
Okay, so I misunderstood you. I was like, oh my goodness, girl.
Oh no.
Okay. So, what are the top three things that scared you or currently scare you, and how are you overcoming them?
Um, Gosh, patient coding is the thing that scares me the most.
Mhm.
I had been fortunate enough to make it a year and a half, almost 2 years in nursing without ever having a patient code on me.
Oh,
That has
wow.
now ended. But just, I was always scared that I wouldn't react quick enough, that I wouldn't know what to do. Um, but the one thing I will say about being in the ICU is you're never alone. And when you
Right.
call for help, there are 15 people there en masse to help you. They're not going to leave you just struggling. Um, I think another thing that has scared me is just, I mean, you build relationships with the same doctors on the step down unit that you do in the ICU, but
Mhm.
because it's a higher level of acuity, I always worry, do they trust me with these patients? They
Sure.
trust me with their step down patients, but are they going to trust me with these patients? Am I going to know enough and do enough and be on top of it enough to take care of these patients? And I think a benefit that I have with that is I do ask a lot of questions. And so they know that I'm not ever going to just not ask, or I'm not going to
Sure.
let something go without questioning it. Um,
Mhm.
and I mean, in the ICU, people die more, and that's
Yeah,
scary, and it's learning how to deal with that. So I think those are the things that have scared me the most.
absolutely. Marie says, I've known Jamie since before either of us were nurses. I'm so proud of her becoming a CVICU nurse, and I'm kind of envious. And then, yeah. So, let's see. Was that three? Yeah, you did say three things. Okay. So, what has been your biggest challenge so far? You may have already addressed it, but
Actually, the biggest challenge that I've run into, I think, is specific to my hospital. And the
okay.
fact that we don't have protocols for a lot of things. It's kind of surgeon dependent, and just trying to learn what each surgeon wants and what they're comfortable with us doing. Um, we have a lot of autonomy in general in the hospital that I work in, but even more so in the ICU. And that's scary because you're always questioning, is this the right thing? And I know that at any time I can pick up the phone and call the surgeon and say, I'm just not sure what you want me to do, sir. But they really want you to have that kind of autonomy. And, but we don't have a lot of protocols to kind of back it up. So that's been a very challenging thing.
I could see both sides of that. One of them being very freeing and loving that autonomy, but as a new nurse, struggling with, I don't even know what direction to take
Yeah.
without a protocol. But I just recently read this amazing study that was done about critical thinking. And they say that the more nurses that rely on protocols and have to have that protocol in their hand before they can move forward are less likely to be adequate critical thinkers. Because you're relying on this piece of paper to tell you step A, B, C, D, when really sometimes you just have to look at your patient and
see what they need.
Yeah.
Yeah.
So
Yeah.
I think in the long run, it will make you a better nurse and stronger critical thinker overall.
Yeah.
Okay, so best advice for a nursing student interested in pursuing the CVICU?
Learn your hemodynamics. That everything you do in the ICU is based off of hemodynamics. Is this patient dry? Are they fluid overloaded? What do their filling pressures look like? Do they need fluid? One of the things that I've come to realize is that most people, even if they have a history of CHF and stuff, need fluid. These people come to us from the OR, they've been under sedation and analgesia for hours, and they're dry as a bone. And if we fluid resuscitate them adequately, then we might not have to start them on drips like Levophed and neosynephrine and things like that. But knowing your hemodynamics, and if they're adequately fluid resuscitated and they're still needing that support, what are you going to start and why? figuring out what your drugs are, what they're used for, what, are they alpha or beta? Are they inotropy or chronotropy? Those are the things that I would start really self-studying, because that's what being in the ICU is about.
Awesome. So if you said, okay, give me the first top 5 drips that I should study if I want to go to the ICU. What are the top 5 that they should start with?
Epinephrine, neosynephrine, levophed, vasopressin, and dopamine.
Perfect. Awesome. All right. So those of you looking at the ICU to start, there you go. There's your little chore list. So insight or advice for someone looking to transfer from the CVI into the CVICU, does that look different from a nursing student or new grad to someone who has experience and wants to transfer there?
I think it is different because they do have some foundation under them that's going to help support them a little bit better. No matter where you're going to go, look at what classes your facility offers through education and take them. Take everything available to you. And it's all the same. Do a lot of self-study. Know your hemodynamics. Talk to the ICU nurses where you're interested in going and get their buy-in on you. I worked really hard to get the ICU nurses in my hospital to trust me and to know that I'm a good team player. And our facility does things a little bit different. And we actually had to get letters of recommendation from current ICU nurses as support coming into the ICU. And I had no problem getting them because they knew that I was motivated and that I would do a lot of self-study and that kind of stuff. And I think having that buy-in from the nurses you're going to be working with is huge, because they're going to be willing to precept you. They're going to be a huge support for you. They're going to be the ones that are answering your questions, that are really being your support and helping you learn through that process.
I think that's a really interesting stepping stone into the ICU. I love that.
Yeah.
Does that aid in your retention as a staff? When you guys bring people into the ICU, do you feel like that creates a stronger team bond and aids in your retention of nurses on your unit?
I do. I think if you have the support of the people you're going to be working with, it's going to be a better, more comfortable environment than if they were looking at you thinking, gosh, I really don't know if she's ready or if she's going to be a good fit or whatever. You want it to be as smooth of a transition as possible, because you want to be comfortable going to these people and asking questions. You want to know that they're going to support you. And I think it just, for everyone, makes it a smoother transition, which in the long run makes it better for patient care.
Sure. So whether you work wherever you work, I think that like peer interviewing or having recommendations from your ICU in order to, step up if you're on a step down unit or something like that. I think that's a great implementation for us as nurses, maybe that we could take that to our current hospitals. That sounds like a great method. I like it. Okay, so what are the characteristics that make a nurse successful in the CVICU?
Obviously, having great critical thinking skills. I'm a firm believer that that's like an innate thing that people either have or don't have. I do think it's something that can be learned, but I think that if it's not something that somebody is just innately good at, you can learn critical thinking skills, but you might not be able to kind of take that into a higher acuity like that. I think being super organized and just able to kind of assess a situation quickly and know what to do, or even where to start, being able to having a great memory, because even though I use a paper SBAR and I write everything down, I know that if my patient codes and I'm on the phone with the doctor, he's not going to be happy if I have to look for my stuff to tell him what the latest ABG was. I need to be able to kind of just roll that off the top of my head if I'm not in front of a computer or in front of my stuff. And really being motivated, being self-motivated, because you do have a lot of autonomy in the ICU, and there are days that you might be in a corner room recovering a patient and everyone else is busy and you're kind of on your own. If you need help, someone will come, but you know, they all have their own patients too. And so kind of being able to figure things out on your own is kind of big.
Sure. Okay, what does a typical day look like for you?
I have no idea. Because nothing is typical. You know, it really just kind of depends. I think it's hard for me to say because I am still on orientation. You know, I've been fortunate to have such a good orientation experience and do a lot of different things. I might start my day with 2 post-op day 1s or post-op day 2s, transfer one off the ICU, give the other one away, and then help recover a heart. Or, you know, I might start my day with a 1-to-1 that needs to be extubated, and then we'll pick up another patient. Or I might start my day with no patients and then recover 2 thoracotomies or carotid endarterectomies. And so there's just no typical day, which I really actually kind of love.
Yeah. So when you guys recover hearts, so I'm PICU is my specialty. When we recover hearts, we have 2 nurses at the bedside. We're doing 2 15-minute chest tube outputs or more if we've got a lot of output going on. What does recovering an adult heart look like? What is that process?
So it's a 1-to-1. For about the first 15 to 30 minutes, there are a million people in the room because the anesthesiologist comes, respiratory therapy, we're getting the patient settled.
Sure.
You know, we're drawing labs as soon as they get into the room. We're checking Q 15-minute chest tube output for about the first hour. Unless they're bleeding, then we continue that. You know, we're giving fluid, we're, you know, making sure that the patient is as stable as possible until they're warm. And then we do our chest x-ray, we do our EKG, and if everything looks good, we start waking them up to extubate. So we move pretty quickly with adults, as long as there's... Oh yeah. I have had the experience of people coming out and bleeding a lot and not being able to extubate until the next day, but we've also had patients that we've extubated within 5 hours of coming out from surgery. So it's pretty cool. It's pretty cool.
Yeah, that's really neat. So what do you love most about the CVICU?
I like that it pushes me out of my comfort zone. I feel like I'm learning a lot. I love to learn and be challenged, and I'm definitely challenged on a daily basis. I love the acuity of the patients. I love that, just kind of seeing how everything works together, and I love watching when I up titrate a medication, how it affects their SVR or their CVP or their PA pressures, and just kind of putting all that together. But I also love having a super critically ill patient that we see get better. That's a really good feeling.
Yeah.
That's what we're there for. And so to see that happen is pretty cool.
That's awesome. And then the hardest part of your specialty?
People dying. People die in the ICU, and it can be really difficult when you work so hard to try to make a patient better, and it just doesn't happen. And that's very difficult to deal with. I had my first experience like that pretty early on in this process of orientation, and I was super thankful that I was able to see it through with that patient and the family, and I was there when we withdrew care, and then I had 8 days off, which I really needed because it's very difficult. You get attached to these patients and their families, and you know, you're working so hard, and to just not see it happen is is hard.
So what's the average length of stay in your ICU?
Because most of our patients are surgical patients, 3 to 4 days.
Okay.
And then we move them out to the step down unit. We'll have people that are there longer, but average is, 3 to 4, maybe 5 days.
Okay. That's awesome. Does anyone else have any questions for Jamie? Anything else that we didn't already cover that you'd like to know? Those of you who are watching? Well, Jamie, if we don't get any questions, I appreciate you taking 30 minutes of your day and chatting with us on your day off. And enjoy your kiddos' last few days out of school.
My husband took her to get a haircut, so I'm actually going to have peace and quiet at my house to work on stupid statistics homework.
Oh, why are you taking statistics? Are you getting your BSN?
I am, and if I pass this class, I'll be done in December, so.
Statistics was, I'm sure it'll be different for you, but I hated statistics with everything in me.
Me too.
And never used it again, thank goodness.
Yeah, well, I figure I'm not going to be a nursing researcher. I'm never going to do management, so I don't really need it.
Right. So, well, plow through it. You'll do great. I appreciate you giving us your time.
Well, thank you so much for asking.
All right, well, have a great day, okay?
You too, thanks.
Bye.
Bye.